All right. Welcome, everybody. There's going to be more people joining, I'm sure, as we get going with this, but this is year 2 of our clinical educator webinar series based on the guidebook for clerkship directors that the Alliance for Clinical Education publishes. In the chat, I'm going to stick some of our standard disclaimer stuff as far as the CME credit and things like that are concerned. But in the meantime, I'm going to turn it over to Karen and Tracy so they can get started with their presentation.
All right, thanks very much, Gary. My name is Karen McDonough. I'm an internist at the University of Washington, and I am joined by Tracy. Do you want to introduce yourself, Tracy?
Yeah, hi everyone. My name is Tracy Brazg, and I'm the director of the Interprofessional Education program at the University of Washington.
And I direct our pre-clerkship clinical skills course, and I'm the point person for the School of Medicine in IPE for our learners. So what we're hoping to do in the next hour or so is to think about strategies to efficiently connect clinical learners with their interprofessional colleagues, whether those are other interprofessional students or practitioners, and to think about assessment strategies for interprofessional collaboration for medical students, which has been challenging for us, honestly, and probably challenging for many of you as well. We're going to, whoops, I'm not sure if that's showing up. We are hoping, Tracy, are you seeing a Slido join QR?
Not yet.
It's flashing past me. I was hoping
I
we
might be
could do
able
some
to
polling, but maybe we cannot.
I might be able to copy and paste it. Let me see
Okay.
if I can grab it from the slides.
All right. So Tracy is going to copy and paste a join link for some polling that we're going to try to do. If that doesn't work, we will use the chat instead. So all of you, I'm sure, are familiar with LCME element 7.9 on interprofessional collaborative skills, which tells us that we need to ensure that the core curriculum prepares our students to function collaboratively on healthcare teams that include health professionals from other disciplines as they provide coordinated services to patients. These curricular experiences include practitioners and/or students from other health professions. In a webinar in April of 2019, the LCME provided a little bit of additional guidance to schools on what they are looking for. They hope that the curricular experiences that students have are based on learning objectives that have measurable outcomes, include required sessions covering foundational knowledge, include participation in practical, real, or simulated collaborative patient care experiences, are designed for the learning level of the students and appropriately placed, include participation by students and/or practitioners from other health professions that are relevant to the learning objectives, and include assessment of every student's attainment of the objectives of the experience. Tracy has posted the link to join the poll in the chat. If folks wouldn't mind doing that, we will get to a poll in a slide or two. In that same webinar, they shared information about what 143 schools across the country were doing as of the 2017-18 academic year. 12% of us had IPE in only 1 year of the curriculum. About a third had IPE experiences in 2 years of the curriculum. About half of that was in years 1 and 2, and the other half presumably included some time in the clinical phase. About a quarter of us had IPE experiences in 3 years and another quarter in all 4 years of the curriculum. The webinar also presented general goals of required IPE experiences across the country. Almost everyone was hoping to familiarize medical students with the roles of other health professions. Most wanted to teach specific content related to team functioning and practice clinical skills for a healthcare team. The majority, hope to teach clinical and interdisciplinary content areas, and under half wanted to provide supervised care to patients within required clinical experiences or service learning that involved students from other professions. 49 schools reported that they were teaching specific content areas to interprofessional students like humanities or ethics or law, and this might or might not meet the definition of IPE, if students were sitting in chairs beside each other, what Tracy likes to refer to as butts in seats IPE, it probably is not really forwarding students' collaborative skills, but if they were interacting with and learning from each other, then these types of activities might have met the goals of interprofessional education. So I will pop these bullet points back up again and ask you all to think to yourselves for a moment, what has been most challenging for you in thinking about IPE in the clinical phase of training? Maybe it's one of these bullets that's listed here, or maybe it's something else. And after you've had a moment to think about it, I will, man, I'm not showing these whole slides. Very odd. Try to, well, I don't think I'm going to be able to see your answers actually. So let's use the chat. Let's forget about the polling and use the chat to share what it is that's been most challenging at your school about implementing IPE for clerkship-based students. So interacting with clerkship directors to get something implemented, how to have role modeling from clinical faculty and trainees in GME setting, ensuring that the people our students are working with have appropriate role models to follow. Scheduling, I think scheduling is the top challenge for every single IPE activity ever in the history of the world. Working with all the different programs, so scheduling, coordinating scheduling, and underscoring the why, scheduling. Gary's noting authentic experiences and not the one-off big group IPE day types of activities. Getting curricular time, especially across the schools, scheduling. So a lot of common issues that are coming up for people. And I hope we'll be able to think through together and share some ideas for how to get around these very common problems that affect schools across the country. So I wanted to share a little bit about what we're doing here at the University of Washington, not because we're perfect, but because we've had the struggles that you all are talking about, and I think maybe illustrate some of the challenges, and perhaps we're starting to find some of the solutions. So we address foundational knowledge early in our curriculum. In year one, our medical students do a uniprofessional session on working and learning in teams, and then participate in a 3-part interprofessional classroom series that Tracy coordinates. This has an introductory session with other health sciences students, which thank goodness is back to in-person this year. Students have a choice of one early evening Zoom session on a topic that is of interest to them and involves students from multiple professions. These topics might include interprofessional ethics, geriatric care, care of patients with substance use disorder, something that's additional to the curriculum for all of them, but engages different students' perspectives. And then we wrap up with a year-end reflective session with other health sciences students. Our medical students also have a longitudinal primary care clinic that begins halfway through their first year, where they have an opportunity to observe and participate in team-based care in an authentic way. We ask them to shadow other health professions in that primary care setting, and then complete a written observation and reflection on teamwork at the end of their first year. In year two, we do a half-day interprofessional simulation with students, or at some of our regional campuses that don't have other health profession students, practitioners from other professions, to practice team communication and team-based care. One of our biggest goals in this foundations phase is really to prime students to recognize and learn from interprofessional experiences in the clinical phase, to get them ready to recognize when there's an interprofessional learning opportunity happening in their day-to-day work on whatever clerkship they're on, and to make the most of that experience. I'm going to shift things to Tracy for a moment to talk a little bit more about what we're hoping to accomplish both in the foundational phase and in the later phase of our students across professions development.
Yeah, thanks, Karen. It's always great to remember what is happening in the School of Medicine specifically, even in our own institution. So thanks for that overview. Okay, so I'm going to talk about something that I feel maybe passionate is an overstatement of how I feel about this concept, but I feel that it is really useful. And it has really impacted the way that we at University of Washington have thought about how to develop and create our interprofessional education experiences, but not only how we create them and what we're trying to teach in them, but also why we are doing interprofessional education. So this idea is, it's an idea called, this is a little bit of a theory burst, I guess you could say. It's an idea called the T-shaped professional. So, you know, in each of our professions, educational settings, we're teaching our students to have and paying attention to sort of this idea of professional identity formation. And, you know, that idea of teaching students how to think, act, and behave and feel and align with the values of their own professions. But what we are also trying to do with IPE is to train our professional students to also identify as part of a healthcare team, as a member of an interprofessional team. And so this is where this idea of a T comes in. This is really a visual image of the incorporation of kind of a uniprofessional identity as along with an interprofessional identity that allows us to become effective collaborators. So I think let's go to the next slide and I'll talk a little bit more about what this means. All right. So this is part one of a two-part image, but the idea here with this T-shaped professional is that if we only tend to our own professional identities and we don't sort of develop ourselves as these T-shaped professionals, then we end up as a whole bunch of single disciplines who might actually end up in a team setting together. So in this visual, you can see the box is intended to be the team setting, and there are a bunch of individual professionals who are inside that box, and they are collaborating and they are part of a team. But they are collaborating maybe not in the best way. They're collaborating in a way that we call multidisciplinary collaboration. It might not sound bad. It might sound like a good goal to strive towards, but actually I think we've learned over the last few decades that we can do a lot better than this. And so if we look at now this layered on image on the bottom, when we shift the focus to one that encourages us to be, not only our students, but us also, to be T-shaped professionals, we make room for sort of the intentional growth that's needed to participate more effectively on a team. And so IPE is one of the things that helps to fill this need, but really this is a lifelong journey of self-development to figure out sort of how to build this crossbar of the T, which are teamwork skills, to then be able to go into a team setting and actually collaborate in a more interlinked and intentionally integrated way, to be able to break down silos that can be detrimental to all of us in healthcare. And so I think the idea here that I like to drive home with students and the faculty who we work with, who are teaching, is that teamwork isn't a given. Like, we don't just all get our education as healthcare professionals and then go out onto our teams and just as a matter of being there together, we function effectively. It actually takes some tending to and some intentional energy and education and self-reflection and self-development from the early stages of learning all the way through our professions to be able to show up into these interdisciplinary spaces and actually interlink with each other in meaningful ways to break down silos and function effectively as a team. And so that's the idea of the T-shaped collaborator, the T-shaped professional. I think there's one more slide, Karen. Yeah, so what are these teamwork skills? You know, I think most of you probably know about the IPEC core competencies for collaborative practice, and those are important and dear to us, but we've sort of iterated on those core competencies for the purposes of sort of the foundational interprofessional education that we are doing here in our institution and in the foundational learning phases for our students. And so we accept 3 of the IPEC core competencies as being 3 of the skills that we're trying to teach. The first is an understanding of everyone's roles and responsibilities, as well as those of their interprofessional colleagues. The second is that we hope to improve and pay attention to communication and also interpersonal skills. The third is that we try to build experiences for students where they have the ability to learn how to, or they have the opportunity to learn how to work with people who both have similar and different values than themselves. And so we spend time sometimes talking about our values or implicitly, explicitly talking about our values, for example, related to patient care or a case we're discussing. And we talk about how we have some similarities and some our professional cultures are similar, and in some ways we're different, and how do we sit with both of that? And then the place where we diverge from the IPEC core competencies, which put teamwork as the fourth competency, for us, our fourth skill or competency that we try to teach too is something that we call collaborative ways of being. And these are things like humility and curiosity and generosity and open-mindedness and non-defensiveness and critical self-reflection and many other things that you can think of as kind of the personal attributes of people who tend to be good at teamwork and good collaborators. And so we have replaced the teamwork IPEC core competency, which we think really comes kind of later in practice, where people actually are really functioning as teams, and in our foundational work, I think with students, we try to encourage this kind of personal reflection and personal skill attribute development as being really important.
Thank you, Tracy.
Yeah.
So after laying that foundation in the first part of our curriculum, we hope that students will naturally progress in developing their collaborative skills in the clinical years. And let's talk about 3 different phases of those clinical years: required clerkships, the sub-internship phase, and the transition to residency. So in our required clerkships, we too have had quite a lot of difficulty of identifying any clerkship director who says, yes, I would like to take a required IPE experience on as part of the clerkship. You may not know this, but the University of Washington has 6 regional foundations campuses over a 5-state region. After completing their foundations phase at one of those sites, our students do rotations all over Alaska, Washington, Wyoming, Idaho, Montana. And so we have a lot of rotation sites that are very geographically distributed, which just adds a whole nother layer of challenge. Facing some challenges in finding that time and that buy-in from clerkship directors, we actually highlighted the importance of interprofessional collaboration for students by making it an element of their required clerkship evaluation. There is an item on 5 of the 6 required clerkship evaluations that is roughly the same across clerkships, with faculty observing and commenting on students' ability to communicate and work effectively with other healthcare professionals as a member of the team. Now, like many of the items on clerkship evaluation forms, these are mostly assessed by direct observation by faculty and residents. And one big issue for us has been that, again, given our huge number of clerkship sites and clerkship faculty, I do not think, have a shared mental model of what this looks like or how we would differentiate someone who is consistently performing as an integral team member or notably enhancing team functioning. So there is certainly area for improvement here. But I think that one thing that having this on the evaluation does is it highlights for students that we think this is important and you probably ought to pay attention to this. So this is not high level or fine-tuned, but I think it does make our students think about this as being something important, something we value, and something that we're paying attention to. The other challenge with this is, how do we actually see this? How do we know when our clerkship student is performing as an integral member of the team? What are the authentic ways that we can observe interprofessional collaboration on clerkships? I work at our main hospital, the University of Washington Medical Center. Most of our students do at least 6 weeks of their internal medicine clerkship in Seattle at one of our core sites. So most of them will rotate through either the hospital where I work or 3 other academic centers in Seattle. At those hospitals, pharmacy students are assigned to the internal medicine teams. So when I'm on service, there's actually quite a bit of opportunity for the pharmacy students who are following all of the patients on the team to collaborate with the medical students, either around a specific patient care task, a medication review, patient teaching, or research and teaching for the team. So that feels like an authentic, high yield, real opportunity to encourage students to collaborate that doesn't require a lot of effort on my part and offers benefits to both the involved students, the residents on the team who might learn something from them, and the patients on the team who might get a little boost in the level of care from these students who are really attending to their issues. So that feels high yield to me, and it's something that we've talked about trying to boost by having these pharmacy students working with us. Another authentic interprofessional collaboration that happens in my setting is nurses at our hospital join bedside rounds. And the same is true at the other main hospitals where IM students rotate. All team members are oriented to the benefit, structure, and etiquette of interprofessional rounds, i.e. making sure everyone in the room knows who each other is, really being respectful, inviting input from our colleagues in nursing, and making sure that we're all part of the dialogue in deciding what the plan for the care is going to be. So the MS3s are oriented. The MS3s are actually presenting and inviting input from the patient's nurse and summarizing for the patients that they're following. Many teams also make the MS3 responsible for contacting each patient's nurse as the team walks to the room. Now, that might sound like a job that is not that exciting, but our MS3s actually kind of take pride in being the person who is coordinating this element of rounds. And I think it maybe gets them to buy in a little bit more to this process. And then as appropriate, students sign in as first contact for their patients. I'm sure all of you would agree that orientation to what that means and guardrails for when someone else absolutely needs to know right away about something that a nurse or other provider texts about is critical. But I found that actually most students after the first week or so are trustworthy to be able to take that first call. And Epic Secure Chat actually has really taken off in our hospital. I hardly ever get paged anymore. Almost everything comes through Secure Chat. And so that actually allows me a greater level of confidence with having students be the first contact, because I can tell them, hey, if there's anything really exciting happening, just add me and the resident to the chat right away so that we can keep track of what's happening. And it also lets us see both sides of the conversation. So there's a question in the chat about which rotation doesn't include this on their evaluation. And I will confess that it's actually the internal medicine clerkship, but we are probably moving towards including it on the IM clerkship as well. So I guess those are some ways that we've found to have authentic experiences that are not based on finding specific time or having a specific group of learners gather at noon or whatever, but really do feel like they're pushing collaboration and communication opportunities for our students and other people that they're working with. I wonder if anyone else has something that they'd put in the chat that is a true, authentic collaboration opportunity that you've found for your clerkship students to have. Gary, you have.
I've got a quick question. How challenging was it to get, say, pharmacy students and or some of these other professions to agree to go on rounds and do some of these things together, so that way things collaborate? Because like you mentioned before, time is, and people in the chat mentioned, time and scheduling is usually the biggest challenge. So was it a heavy lift to get people to buy into doing this, or was it fairly easy?
So the Pharmacy students are here as part of their core rotations. So they're not here because they were, we were pulling them in. They're here because they need to do these clinical experiences. And actually, historically, the pharmacy students spent a little bit more time with the attending pharmacists, but as their job responsibilities increased, it became more efficient to assign the pharmacy students to really spend more time with the team rather than spending more time in the pharmacy workroom areas. And so that's ended up, I think, being beneficial all around. So we didn't drive that, but I think everyone's been happy with it. Similarly, we didn't drive the process of nurses joining bedside rounds. That is something that I think comes out of Emory, the benefit of structured interdisciplinary bedside rounding. And so that was a hospital cardiology medicine service drive to make that happen. There is a little bit of an element, I can imagine, would I recommend to colleagues who are working at a community hospital that they should go right ahead and encourage their students to be the first contact for nurses who are calling about issues with their patients. There may need to be some groundwork laid for that. I certainly hear from nurses I've worked with for a lot of years about sometimes what a pain it is to have to talk to the MS3 first or the MS4 first before getting to someone who can give them an order for whatever it is that they're hoping to accomplish. That said, I think again at our core teaching hospitals where we have many nursing students, many pharmacy students, many medical students, some social work students, it's such an environment of education and learning that I think to some degree we all maybe put up with is the phrase that's coming to mind, but it's probably not the best phrase, but we all work with each other's learners. And so I think it's worked okay in our setting. Amanda, something to add?
So we actually have our students shadow another health professional, and then we have prompt question, like reflection questions that go with that. And then we also have them at that same time interview. So, but we have recognized that there's really this need to get the students together, right? Because they might observe what another health professional is doing, but I think within year 3 and 4, it's still important for them to work with the pharmacy students or the nursing students because it's just they're kind of at their same level of education. I think it benefits both parties, right? The nurses learn some communication skills and the nursing students do, and in addition to the medical students. We haven't really been successful there, and all of our year 1 and 2 experiences involve other students, but then they get out into the clerkships and that's like disappears because nobody has time. All of our health profession students are going in different directions, and we don't know if there's any students that are within our college rotating at the same place as our medical students. So we've really, that's the only thing we've gotten incorporated so far. I've seen other schools doing a discharge summary plan in an interprofessional group. But I was curious, maybe you're going to talk about your TTR course, what you're doing there, because I think that might be an opportunity to have an IPE event.
Yep. So I will get to TTR for sure. And we are also incorporating a little bit of shadowing at the 4th year level. I agree. It would be so great if we could, and we have talked about this actually a lot of times, if we could reliably get more of our health profession students in their clinical phase together. And like you, Amanda, it has not been easy. It has been made a lot easier by having pharmacy students that are really connected with our teams on a one pharmacy student to one team basis, because the pharmacy students and the medical students actually end up forming a relationship and working together quite a bit. So that's wonderful. But once you get outside that dyad, it's a little less likely that they're going to be working with their colleagues at the same level. So that was the poll that didn't work. So our students in their 4th year are required to do 8 weeks of advanced patient care rotations. This can encompass anything from anesthesia to urology. There are a lot of specialties that have an advanced patient care rotation. 4 weeks of that 8 weeks must be a sub-internship, and those are primarily in medicine, pediatrics, surgery, OB-GYN for the vast majority of our students. All of our advanced patient care clerkships have several objectives that are related to interprofessional care and collaboration. And you can see those listed there. Students' objectives include participating as an informed and efficient member of the team, describing important roles and responsibilities of team members, and communicating with other team members using best practices. And the way they are supposed, oh, whoops, I have another slide. And when we survey students about what their experience is like in these advanced patient care clerkships, what they tell us is that they are very frequently to, in some cases always, taking primary responsibility for patient care, which would include communicating with the other professionals that are working with their patient. They very frequently to always feel like an integral part of the care team. And this one was a different scale of 4 agree to 5 strongly agree. I was provided an opportunity to interact in a meaningful way with other health professionals. So we have this set of objectives for advanced patient care rotations that do include interprofessional teamwork. And based on what the students tell us, they are having an opportunity to practice those skills. On the internal medicine sub-internship, which is completed by a little over 1/3 of our students, we have an activity that was co-developed with colleagues at the University of Wisconsin. Students are assigned reading on roles of different health professionals in inpatient care and discharge planning. They participate in discharge planning rounds. I guess I didn't write that they have a shadowing experience with another health professional, and then they need to submit a written reflection on that experience with the health professional that addresses prompts such as, one thing I learned about the skills, responsibilities, or training, about communication, about what went well, what I would do differently next time. When we took a look at how the initial cohort viewed this experience, a pre-post survey of about 100 students showed movement in the positive direction for most of the things that they were surveyed about. There was an increase in understanding of the roles of other health professionals on a care team. There was an increase in agreement with, it is my responsibility to ensure that everyone has the opportunity to provide input. There was an increase in confidence in the ability to share the medical student's idea with team members from another profession, and an increase in comfort speaking with non-physician professionals about the care of their mutual patients. When we analyzed students' written reflections to get a sense of what they were taking away in an open-ended way, the things that they were saying really aligned again with the IPEC competencies. They were talking about what they learned in terms of roles and responsibilities, interprofessional teamwork, communication best practices, and values. And you can see some of the quotes here. I think my favorite, my two favorite are, I learned that other specialties are putting in just as much work as I do. It's humbling to realize how much work goes into a single patient and that their care is not feasible without a team. A comment about nursing was, it's important to confirm plans and ask opinions about the plans because they are the ones who are executing the orders and they have to be comfortable with the plans. They also spend the most time with the patients and can give really useful insight. And actually, I have one more favorite. Treating other providers as valued peers with invaluable insight into the patient's condition only improves team dynamics and clinical outcomes. So based on this initial sort of assessment of what students were taking away from this activity, we've continued to do it and are thinking about how do we expand this so that it is part of the program for all of our students, thinking whether to expand it to all of the sub-internship experiences, or alternatively, whether to move that back into the required medicine clerkship, but hoping to implement for all students in the upcoming year. There's a question in the chat about whether there were any negative opinions about this team experience. They're not that students noted on their identified reflections. So that was probably not a space where they would have felt super comfortable sharing that they didn't like something about what they were asked to do. I can't remember if there's a de-identified space where they would have been able to share that, but we didn't pick up on negative feelings about it. A couple of things related to transition to residency. So I think that one of the best things we do in our TTR course is a session led by nurses on what to do when you get paged, or perhaps more likely now, epic secure chatted. The objectives that our nursing colleagues have developed are to understand the why behind common pages, to learn how to triage, to build more confidence in responding to nursing pages, and to explore the value of teamwork and partnership. We have versions of this that are dedicated to students entering adult specialties, pediatrics, and surgery as part of a surgery bootcamp program. And our students have rated this really highly. The nurses who developed it really emphasize the ways in which attending to nurse-physician communication can improve the sense of collaboration and improve the patient sense of the effectiveness of care. They've also provided really good nuggets for students on things to do and things not to do, like don't tell the patient that they can eat without entering the order. Don't tell the patient they're going to get discharged today without letting the nurse know. And it's so interesting to see what our colleagues in nursing have come up with that are really directed and actually incredibly helpful pieces of information for our students to understand as they start out as interns. On MedEd portal, you will find published curricula for students who are entering IM, Peds, OB-GYN, surgery. The surgery one is embedded in a surgery bootcamp curriculum. We'd be happy to share our slides that were developed by nurses primarily, if anyone would like to see those. Comment in the chat on the use of word team is vague. And if you ask a student who is on my clinical team, they will focus on the medical team. And I think that that actually is one big downside of the evaluation question that I showed you a few back. They could interpret anyone, the student or the faculty member could interpret team as being the other medical students, residents, attending, subspecialists on the team. We do try to orient both groups of people that when we say other healthcare professionals on a team, we mean other professions, but it is a vague term that could be misinterpreted pretty easily. Yeah, maybe we should say IPE team. That's a good suggestion. So other things that we're doing in our TTR course, we've done an interprofessional simulation with students who are graduating. This was initially developed about 10 years ago with funding from the Macy Foundation, and physician, pharmacy, and nursing students manage acute situations. We have versions of this that include adult cases, pediatric cases, OB cases, de-escalation cases. And overall, student feedback on these has been very strong. Students have enjoyed them, and we've had a lot of difficulty with scheduling. We've had a lot of challenges with faculty recruitment and preparation. And while we initially hoped that this would be an opportunity to really assess teamwork skills as students are preparing to graduate from their programs, it turned out to be pretty overwhelming to get enough faculty assessors and to provide sufficient feedback to have anything other than formative assessment and self-reflection be part of this experience. So there have been a lot of good things about these simulations. We shelved them after trying them on Zoom during the first, or actually 2 years of the pandemic. And we're now rethinking what should we bring back again for this upcoming year. and what might we like to pivot to in the future. I think one big thing to think about is what are the outcomes that we're aiming for with IPE. The Kirkpatrick model is a model that's commonly used when discussing IPE assessment. Level 1 on that model would be, we're just assessing, did they like it? Level 2A would be that there's a change in attitudes or perceptions between the participant groups. The medical students now value the pharmacy students a little bit more and vice versa. Acquisition of knowledge and skills would be knowing a little bit more about what the roles of other professionals are, or knowing about communication skills that will help with interprofessional collaboration. Probably what we're really looking for, ideally, at least with our senior students, is level 3, a change in their behavior, that we can see a transfer of what they learned to what they're doing in that clinical setting. It is unlikely that we're going to be able to see a change in organizational practice or benefit to patients and clients in the setting of our learners. Tracy, can you talk a little bit about this? This, I think, is an interesting way to assess what students are taking away from their IPE experiences that Tracy and others at UW have kind of adapted from a pre-existing survey.
Yeah, sure. So we took you can't see me anymore. We took a pre-existing survey and kind of modified it to meet our 4 areas of learning objectives that we think we're trying to teach towards. And so I think that the evaluation that we do about our classroom curriculum, kind of looking at that Kirkpatrick model, probably stays in level 2B, sort of acquisition of knowledge and skills being the highest kind of outcome that we can aim for. So many of these kind of have to do with that. So we use something called a retrospective pre-post, which is great for a lot of reasons. It asks students to only take a survey one time at the end of their experience. So in this case, we had 686 students who participated in our core curriculum. And so the team readiness survey, we just made it up. So I'm happy. I think we can share our whole survey. I don't see a problem with that, but it's definitely not published. It's also not validated, although we do have an immense amount of data that we've gathered. And I think we did some initial tests to sort of see how these items were hanging together. And I think it actually it's pretty okay statistically. But anyways, so we use a retrospective pre-post, which gives the students the survey at the end of their experience and asks them to think back. First, answer the question. They need to answer each question twice. First, think back to the beginning of the school year or whatever anchor point there is, and think about how you felt, how you would rate your confidence in each of these in this area. And now think to the end of the school year and how would you rate your confidence in this area now. And so the white line is kind of just shows how they rated their own self-perception of their confidence and their knowledge of their own role, their knowledge of other people's roles, their ability to describe their role, their ability and their kind of willingness to share ideas in a team setting, their confidence in their ability to encourage voices and opinions of others, their confidence in their comfort sharing responsibilities with the team, their beliefs about whether the best decisions are made by teams. That was an strongly agree to strongly disagree scale. And then we asked them a question about whether they feel more curious about other professions moving forward in their careers and in their training. We also had them rate themselves, their self-perception of themselves as a team player pre and post. So this slide shows that in each of these areas, students, when reflecting on these questions, perceive themselves to grow in every single one of these areas. And the nice thing about the retrospective pre-post, besides the fact that along with the fact that students only need to fill out one survey, is that it's really easy for us for data management. We're not matching the pre's and the posts and the missing surveys. And so you can read about that survey design. There's a lot written about that retrospective pre-post survey design that you can find online, but we found it to be a really feasible and really like effective and kind of straightforward way for us to be able to see whether any change is being made. And you can run a sample t-test on these also to make sure that that difference is in fact statistically significant with such a large number it is. And so this is just another way of displaying the data for anyone who wants to just kind of see this in a different way. So these are the same questions, but here I just put together a graph of the percent of change. And I thought this was an interesting way to manipulate those graphs, just to show really clearly which of these areas we most impacted, or students perceived us to be most impacting. So in this case, the biggest impact or the most growth that students reported for themselves was around these questions of roles, my own roles, understanding others' roles, and being able to describe their roles to others.
Thanks, Tracy.
Yeah.
Our colleagues in pharmacy actually brought this retrospective pre-post idea to us. And we adapted this survey, I think, from a survey that they had adapted that started with the ISVS, which is a published, validated, I can't actually remember what ISVS stands for. But the other reason that they really like the retrospective pre-post is they felt like students turn up at their program and they think, I am great at teamwork and I know everything I need to know. And so if you survey them actually pre, you might not see as much change as you do when they think back on where they were at the beginning of the program. So that was the other idea that they brought forward.
I also think there's another thing that happens, which is this is almost like a reinforced opportunity to let students know what the goal, what we were trying, you know, what the skills are that we think are important. So they're reading through all of them again, they're reflecting on how they grew with those skills, but also we're sort of like reinforcing like our objectives and reinforcing at the end of the day, sort of like what we hope they would, where we hope they would grow, and also where we think they need to, you know, we all need to continue growing in these areas too. So I feel like there's a little bit of a meta thing that happens with people taking this as well.
And then two things in the chat, question about whether it just assesses kind of our curricular offerings or everything. And we're pretty explicit with students that it's just about like what has happened to you over the last year. So for our students, they're participating in this foundational curriculum with other health sciences schools, but they're also doing a bunch of other stuff. They're going to a primary care clinic, they're going to the hospital with their clinical skills teachers, and we're just asking them to think back to where they were at the beginning of the year and where they are now. And then Amanda, thank you for sharing the original reference to the ISVS for anyone who wants to take a look at that. And as Tracy said, we can share the adaptations that we've made to make it feel like it works for our students. So this, I'm a person who loves a good flow chart. And when I was reading about assessment in IPE recently, I found this flow chart. And the reference is here at the bottom. This was published in 2021. This was a group that did a systematic review of assessment tools and kind of pointed you in the direction that you might want to go to a variety of published tools, most of which are available on the Nexus site that Amanda pointed you to. We have used or tried to use some of these tools, and they are primarily aimed at assessing student behavior in a simulation or a clinical setting. These authors suggest that if we're trying to assess acquisition of knowledge, maybe an MCQ is an okay way to do that. And we really haven't been looking at benefits to patients. I think the thing that I found most interesting here was just the list of published tools that might be available. And I've poked around at a couple of these that I haven't seen before, just to see how they might be useful to us or not useful to us. So I offer this not as something that I'm deeply knowledgeable about, but as a relatively recent summary of some things that you might find interesting. Two of these that we have tried out. One is the modified McMaster Ottawa scale. There's a link here to a publication in MedEd portal. There are actually several other publications related to this. I think the references to all of those are in MedEd portal. This group at the University of Southern California adapted an existing scale for assessing interprofessional teamwork to be used in a team OSCE situation for undergraduate students. The MedEd portal link actually includes a bunch of good tools. It includes the rating scales like that are the form that you see here, as well as more information for raters on what a 1, a 2, or a 3 would look like, and some training videos that get people ready in probably under an hour to be fairly reliable in rating students' abilities. There's both an individual and a team rating scale that are part of this publication. We tried this with simulations for our second-year students. Our faculty felt like, yeah, we understand this, and we felt like we could get on the same page with the ratings that we were providing. The hang-up that we ended up having is that we didn't have enough people to reliably be able to assess students real time. So we ended up, that was immediately pre-pandemic, and we are circling back around to whether we can try this with video or another mechanism that allows us to really apply it in a better way than we were able to. So it seemed like a relatively easy to use tool. It seemed like it was something that our faculty could wrap their brains around without hugely large amounts of training. But it does seem like you need people who are really paying attention to this, either live or on video, in order to effectively apply it to a real situation. Amanda, was there something you wanted to add there?
So just listening. Thank you.
Oh, okay, thank you.
I also, Karen, I just want to say, I think we've had a lot of conversations in our groups about this, like validated tool versus making your own tool versus modifying a validated tool. And I think it's worth just saying, some of you probably already know this, but like a tool that's validated is not validated anymore the second you make a single manipulation to it. And so, you know, I think we just completely renamed the tool that we use. And yes, it was based on the ISBS. It was maybe a modified version of the ISBS, but it wasn't the ISBS anymore, nor is it a validated tool anymore. And I think that's okay. I think it's okay to do that and to not feel like you have to, you know, drop the fancy validated tool if it's not the right tool for you to use to measure your objectives.
Yeah, and I will confess, we changed what this looks like to include what the rater might be looking for in these boxes to make it easier to use. I don't think that messed with the validation, but what ended up being our problem is we just didn't have the person power to be able to apply it effectively in real time. Something that I'm excited about that I haven't actually tried, but wanted to share because it may be of use to you, is something that was just published in the last 6 months or so. This is called the Tool for Observing the Construction of Knowledge, or TALK. And this publication actually goes through the process of developing this tool and faculty's experience with applying it to videotapes of fake learners. So this is not something that we have personal experience with using, but I think the thing I really like about it is, especially with our early students, and even with the pharmacy and medical students that are working together in third year, I'm really interested in how they're learning from each other, how they're sharing perspectives, how their shared knowledge is more meaningful and impactful than the knowledge that either one of them has on their own. And so the items on this scale around sharing and comparing, exploring divergence and disagreement, building new knowledge together, and reaching agreement seem, oh, there's something we can do with that. So wanted to call that to your attention, even though we have not actually done anything with it yet. I wonder if there are other assessment tools that people in the audience have found to be successful, things that you've tried and haven't liked. Maybe unmute and share or pop something in the chat.
Yeah, we use Ripples, RIPLS, and ICAS, ICAS, and IPAS, IPAS, in collaboration with the other healthcare programs. And we try to run them all at the same time so we can look at the data together.
And how do you use that data, Amanda?
Oh my gosh, I don't even think we've been able to really use anything. So our medical school is new. We're on year 5, and we have a IPE day, and we have several small IPE events, but I haven't gotten to the stage where I have enough time to actually analyze the data like you have. So kudos to all the work you've done here.
So here's another poll that doesn't work. I guess I will offer what I hope maybe some take homes are today. First is that there are opportunities for authentic interprofessional collaboration and required and advanced clerkships, whether that's calling out IP collaboration as a goal in objectives, assignments, or evaluation, and potentially, although we haven't been super successful with this yet, maybe some focused assessment on IP skills. We here feel like our assessment of collaborative skills is still really in the development stage. You might consider a retrospective pre-post, which we've found useful for longitudinal assessment of knowledge and attitudes, and think about those two relatively easy to use seeming tools for clinical and simulation settings. Tracy and I were excited to have a chance to talk to you today. We would love to hear from anyone who has questions or maybe wants to follow up on anything that we've shared or offered. Tracy, I don't know if there's anything that you would share to wrap up.
Oh, thanks for having us.
Any last questions, ideas, recommendations from the group? Hi, Alice.
Hi, how are you? So we had such a dilemma with this role identification piece that's so important in the IPEC competencies. And we were doing sessions, one of these, I think it was right, one of these mass sessions once a year where you'd bring all these different people together and figure out how to do role identification and all that stuff, and really felt it was a failure. So we went to like something really extreme, and we're using artwork to discuss teams and then in small groups with facilitators. And first there's an intro, and then we break into small groups with artwork and we discuss teams based on the piece of artwork and try and bring out the different roles that people have, but using the humanities as a connection point for everybody. It was well received. We do it on Zoom now because of the pandemic. In the past, it was face-to-face. I don't know what it's going to be this year. It's not till April or the spring sometime. So I don't know. But I just wanted to mention that we totally shifted from like a case-based didactic to the use of humanities to get to understand teams and roles.
That is such an interesting idea. I would love to email follow up with you and find out what images you're using, what students
Right,
are.
I would connect you with our art educator who's helping to support this as well. She's amazing. So if you want to do that, I will connect you with the art educator.
Thank you, Alice. William.
Yeah, you were asking about instruments. We were using mostly the Spice R, which was fairly easy to use. It's more about research than student evaluation, but it's, I think, usable in either setting.
Thanks for that. Tracy, have you thought about that one at all? I don't think I really have. I've seen it, but haven't delved in. Hi, John.
Hi, just to follow up on the survey you're using, the pre and post. You mentioned, and you may have said this and I missed it, but do you do that every year to see longitudinal growth from year 1 to year 4, or is it, how do you do, how have you been doing that? Because you mentioned you did it, like you said, how answer these questions based on how you were at the beginning of the year, and then now answer them how you are at the end of the year. Do you do that over 4 years every year, or?
I believe that our School of Pharmacy does it
that's
every year. In the School of Medicine, we have done it at the end of year 1, at the end of year 4. And I don't know why. I think because we have a fairly captive audience at a certain point in each of those years, but we haven't done it on a yearly basis. And I think that most of the other programs are doing it at the end of their participation in that foundation series year. Is that right, Tracy?
That the who is doing it?
I think like nursing, everyone else is doing it just at once, right?
Yeah, just the one time. Yeah.
Do you know anything about anybody looking at it longitudinally, like, you know, to see if there is that growth from year 1 to year 4? It, you know, it feels like, it seems like it, you know, and where we have, you know, some things we've done with our students, but
Right. I know our pharmacy colleagues are, and I probably should compare our year 1 and year 4 information, but I haven't done that.
be interesting.
Yeah.
Thank you.
It is interesting also because people rate themselves not very low to begin with. So, because there's like a social desirability, and also even if they don't know that people are looking at it, it's like they want to think of themselves as good collaborators. So I would be interested to know if there is any change in this particular way of measuring this over time, because I don't know that people are really rating themselves as 1s and 2s, even at the very start of their profession. So, yeah.
All right. Thank you, everyone. We've had a lot of people drop off, but appreciate both of you for doing this. We're over the time for today, but this has been fantastic. And many of you have already received the evaluation in your email. So we'll have another webinar next month on health system science. And so, but we really appreciate Karen and Tracy for taking time today to do this. It was really informative, I think.
All right. Thank you, everyone.